Good afternoon again, everyone. Thank you so much for joining us for week 4 of our second annual Health Equity Challenge series. This is our book discussion about Dr. Deirdre Cooper Owens' book, Medical Bondage, Race, Gender, and the Origins of American Gynecology. We are fortunate today to have Charlotte Rich, a PhD student in the History of Science and Medicine program at Yale University. She examines the transnational history of reproductive healthcare and sexuality in the mid-19th century across the United States, Ireland, and the United Kingdom. Her research centers the experiences of working-class Irish women to consider how they engage with various institutions, both medical and non-medical, to procure medical services. She also explores the production and popularization of increasingly nativist, racialized, and class-based ideology about Irish women's sexuality, bodies, and lifestyles during this period. Charlotte is deeply invested in how studying historical inequities in healthcare can shed light on our current systems and practices. Charlotte, the floor is yours.
Hi, everyone. Thank you so much for that introduction. I'll just go ahead and share my screen to show some slides. Can everyone see the slides? Okay, wonderful. So good afternoon, everyone. Thank you again for the invitation to join your discussion today. I'm really looking forward to discussing Dr. Cooper Owens' incredible book with you all and to share a bit about my own research interests. So just to recap a little bit about my research interests, my research generally looks at the transnational history of reproductive healthcare in the 19th century, specifically examining the healthcare experiences of working-class Irish migrant women relating to childbirth and obtaining treatment for complications of childbirth and other reproductive disorders. I also explore how physicians, government officials, and social reformers gained interest in Irish women's health and sexuality, and how the way that these authorities spoke and wrote about Irish women intersected with and contributed to nativism, classism, and sexism. So I'm interested in looking at these different national contexts where Irish women settled in order to consider how their options for healthcare developed differently in each location. But for the purposes of today's discussion, I'll focus mostly on the United States context in order to make this cohesive with our reading. And I'll focus mostly on New York City. So why is Irish migration specifically of interest as opposed to one of the other many groups that migrated during the 19th century? For some brief context, I'm interested in the movement of Irish emigration that occurred during the mid to late 19th century, though Irish people, of course, emigrated long before and after that period. This particular moment of mass emigration was prompted by the Great Famine, which occurred roughly from 1845 to 1849, and was the result of a potato blight, as well as a long-term process of colonial extraction by Britain. This was actually only one in a series of smaller famines throughout the 19th century, but was the most severe. Irish people not only suffered from starvation, a loss of income, and massive population decline, but also experienced successive epidemics of infectious disease and persistent economic depression. The famine constituted a crisis of health and contributed to poor health outcomes for decades to come. It also prompted millions to emigrate. So one aspect of Irish migration that I think is notable is the sheer scale and vast geographic scope. Irish people emigrated in vast numbers to the United States, Canada, England, Scotland, and Australia, and New Zealand, and as this map shows, in smaller numbers to several other regions. Irish migration was also unique for its gender breakdown. In the 19th century, most immigrants coming to the United States were men. However, women accounted for almost 53% of all Irish immigrants in the United States. meaning that they actually outnumbered the men. This is especially stark in comparison to the other large European migration movements occurring at the same time. So this is one example of this is German migration, where women only accounted for 41% of the population. Turning to the early 20th century for some other examples, Italian women comprised only 21% of all migrants from southern Italy, and women only made up 4% of all Greek people entering the United States. Again, Irish women constituted almost 53% of all Irish immigrants in the 19th century, so this stands in sharp contrast to many other groups. This high proportion of women makes Irish immigration an ideal case study for examining the relationship between developments in reproductive health care and immigration patterns. Furthermore, this large famine-era wave of immigration to the United States coincided with the professionalization of specialties that targeted women's health care, namely obstetrics and gynecology. Because of this, as Dr. Cooper Owens shows, Irish immigration and Irish immigrant women often became the subjects of early gynecologic experimentation. By looking at this history of immigration and medicine together, we can consider how the movement of people, knowledge, and practices were key to the development of new systems and methods of healing, while also being attentive to the experiences of patients and the ways that we remember their contributions. On that note, it's important to dwell on the nativist attacks that Irish women frequently faced. As a former colony of the British Empire, Irish people had long been dehumanized and othered by the English, but they faced new discrimination upon arrival to the United States. Here, we have to employ a 19th century understanding of race, which was very different from our contemporary one. Historians of race and ethnicity have argued that 19th century Americans viewed race and color as two separate categories, meaning that a person could simultaneously be considered white while also being racially othered. Irish people fell into this category in the 19th century, meaning that while they benefited from their whiteness, they also faced racist discrimination and nativism. Much of this anti-Irish nativism targeted the general poverty of Irish immigrants during this period, who, after all, were fleeing one of the most significant crises of the century. Nativists also criticized Irish immigrants for their Catholicism, which many American Protestants viewed as disqualifying them from full citizenship because of their supposed devotion to the Pope. Irish women faced a particularly virulent form of nativism, which framed them as pathologically promiscuous, non-normatively fertile, alcoholics, and even as mentally ill. This nativist discourse appeared in popular media like the cartoons displayed here, job advertisements, and even in medical literature, as Dr. Cooper Owens showed in the chapter that we all read. And just to briefly dwell on these images that I have displayed here, the one on the left depicts sort of a comparison between kind of an archetypal Anglo woman and archetypal Irish woman. And here we see kind of this racial othering that was being targeted at Irish women, especially in the way that they were portrayed as animalistic or sort of completely different from, for example, an English woman here represented by the famous nurse Florence Nightingale. And then in the image on the right, we see a depiction of an Irish domestic servant who is hosting a large crowd of men in the home of her employer, and we see her employer's wife entering the scene and being shocked to find this gathering of people. And so this is really engaging with discourses that framed Irish women as kind of promiscuous or not meeting the gendered expectations of the time. This nativism, this nativism impacted all facets of Irish immigrant women's lives, from their options for housing and work to their health outcomes and interactions with medical practitioners. Because of their limited means and the discrimination they faced, Irish women often lived in the tenement districts of the city, like the one pictured here, the infamous Five Points neighborhood in Lower Manhattan, and they lived in overcrowded housing that lacked proper ventilation or sewage. They also worked physically taxing jobs, especially in domestic service, which often paid very little and demanded long hours. Furthermore, many Irish women participated in sex work, either as their primary job or as supplemental income. It was actually quite common for domestic servants to also perform sex work on the side. As Dr. Cooper Owens discusses, participating in sex work not only made Irish women vulnerable to policing, incarceration, and violence, but also exposed them to sexually transmitted infections. All of these factors contributed to Irish immigrant women's need for access to healthcare, which posed a significant challenge, especially for the newly arrived. They faced a completely new medical landscape with unfamiliar options and institutions that functioned completely differently from those back in Ireland. On this point, much of my research is concerned with questions of agency, particularly how Irish immigrant women made choices regarding their healthcare, even when their options were constrained. I'm interested in the various ways that these women provided for their health, even amidst difficult circumstances. So hospitals were, of course, one resource for immigrant women, though they came with significant drawbacks. In the mid-19th century, most Americans viewed hospitals as the absolute last resort and the place where only the poorest members of society, without any family or connections, went to die. It was very unlikely to actually achieve treatment in a hospital, and they functioned more as almshouses or poorhouses than therapeutic medical institutions. Furthermore, before the acceptance of germ theory at the end of the 19th century, hospitals were plagued by infectious diseases and were often also described as being infested with rats and other vermin. That is all to say that most hospitals would not have been an appealing option for Irish immigrant women. Specialist institutions like the Women's Hospital, pictured here, challenged this notion and attempted to actually treat women's reproductive diseases and disorders. This hospital was founded by Dr. J. Marion Sims in 1855 in New York City following his experimentation on enslaved Black women in Alabama, and the hospital treated many Irish immigrant women in its first years of existence. Sims touted the specialized skill and expertise of the medical staff at the hospital and imagined it as a center of cutting-edge medical research and education. While this meant that patients at the Women's Hospital may actually receive some form of effective treatment, they likely would have been observed by a crowd of male medical students whom Sims invited to learn his newest surgical techniques. Sims' eventual departure from the hospital actually resulted from a public conflict with the board of lady supervisors of the hospital, who objected to these large crowds observing surgeries in the hospital because they believed that this would threaten both hygiene and the patient's modesty. Finally, working-class patients were often expected to work as unpaid nurses during their stay in the hospital, which of course seems counterproductive to the process of healing. While this was not unique to the Women's Hospital, and this practice occurred in many other hospitals, it seems that it would have affected women's decisions whether or not to seek care at this or other hospitals. Considering options outside of hospital care, many Irish immigrant women likely chose to give birth and receive their health care with the advice of a midwife in their own home. After all, traditionally, Irish women had managed their health care with the help of midwives or handy women, typically within their own female communities. Given the large community of Irish women in cities like New York, it is very likely that this practice persisted. Finally, non-medical charities would also have served a role in Irish women's healthcare. These charities ranged from homes for poor women and Protestant-run institutions that aimed to, quote unquote, reform immigrant sex workers, to charities and hospitals run by the Catholic Church. These charities would refer poor women to specialist institutions like the Women's Hospital, and would even aid in the postnatal care of mothers and children. Irish women appear frequently in the records of many of these institutions, showing the important role that these charities played in immigrant women's lives. Finally, due to the disproportionate policing of immigrant neighborhoods, many Irish women were incarcerated in prisons, jails, or asylums, making these carceral institutions a likely provider of healthcare for Irish women, in spite of how counterintuitive that may seem, based on the significant harm of policing in Irish immigrant communities. To conclude, I want to speak briefly to the contemporary ramifications of this history. While we no longer see Irish American women as the targets of medical racism, countless other groups have, of course, suffered from the discrimination, neglect, and abuse in the course of accessing medical care in the United States. We've seen this with forced sterilizations of migrant women from Latin America occurring at the southern border, and more broadly with the difficulty that undocumented women face accessing reproductive health care without insurance. A historical approach cannot provide any easy answers to these contemporary problems, but I hope we can continue to discuss these connections between the past and the present for the remainder of this session, and I would be eager to hear your thoughts on these issues. So now I'll take the time to raise some themes and discussion topics, if that's what's next.
Absolutely. Thank you so much, Charlotte. One of the themes that is really at the forefront of my mind is the wage labor and health. And when we look at how some communities internationally, locally, have these phenomenal healthcare systems, and there's this disconnect where many of those who, are potentially doing hourly wage jobs are unable to access the care and the facilities that they help run. What are your thoughts on that?
Yeah, absolutely. Yeah, I think this question of who's doing kind of the hidden labor in hospitals and other healthcare institutions becomes really clear in this history. Like the fact that there are all of these informal systems of nursing, like with nursing not yet being like fully professionalized in the mid-19th century. So I think we see this kind of these boundaries being placed around who is able to enter these institutions and on what basis. Like with these Irish immigrant women, we often only see them able to access this like very specialized healthcare if they're also going to provide nursing to other patients or potentially do laundry in the hospitals, something like that. Or if there's this kind of unspoken assumption that their healthcare will become the basis of potentially a medical journal article, which, as we see in this chapter, Dr. Cooper Owens really highlights how these medical journal articles promoted all sorts of nativist ideas about these patients. So yeah, we see even when Irish women were able to access this, like, kind of at the time, very specialized kind of cutting edge care. There were all of these conditions for that access. And I think, yeah, your point about kind of labor being this really key condition is, I think, absolutely a very key part of this history, and one that I really appreciate the connection you were making about, yeah, all sorts of labor being necessary to hospitals and healthcare institutions today, but those people doing that work not necessarily like actually having access to healthcare.
Thank you. We have any questions or comments? Feel free to put it in the chat if you're unable to come off mute. Could you talk a little bit more about contemporary immigration policy implications for?
Yeah, so I'm really interested with my research and more broadly with scholarship in the history of medicine, how I think the contemporary relevance and kind of resonance of these histories can be really useful for kind of highlighting that many of our contemporary issues are not actually new, and that, you know, they all have much deeper historical roots. So I think with the issue of immigration and healthcare access, I think it can be really helpful to think about kind of all of the different kind of moments in history where we see similar problems of immigrant communities struggling to access healthcare in their new setting, or potentially, you know, facing poor treatment or even abuse or non-consensual experimentation, issues like that in this new healthcare setting. And you know, this is an area that I would be interested in hearing where others see kind of any reflections between this history and our current moment. But I think just the few topics that I raised about, like, we of course continue to see, unfortunately, forced sterilizations often of, this has happened over the past century, but even in the past few years, we saw this happening in ICE detention centers, and kind of this ongoing problem that we have where migrant women, their health is struggling because they either, you know, cannot access healthcare due to lack of insurance, or we see actual like medical abuse occurring. So yeah, I just wanted to raise that as a potential discussion topic, because I think it's one of the ways that we see this history as continuing to be very alive in our current moment.
Absolutely. I don't know if it would help to maybe add another question onto that, or maybe it's a different question altogether, but what can we do in our respective spaces and spheres of influence to help impact the, I guess, current status of what's going on, especially when you mentioned like the forced sterilization at the ICE detention centers and things like that. You know, it's more than policy. Policy almost seems too kind of like a cloud in the sky. What are some tangible actions that we could do to help affect change in that regard, to enforce or reinforce protections? Are there protections that exist and it's just not being followed? Or, and I'm asking because this is, you know, I feel like if you don't necessarily interact with the topic of immigration policy in your like day-to-day life, there's a lot of ground floor foundation learning that needs to happen before you can kind of unpack the issues. Even when we talk about the word access, what does it mean? Is it walking in the building? No, it's like being able to navigate the systems and have the resources to do so, and being treated fairly and with respect and kindness throughout that process. So I know I'm saying a lot here, but if you could maybe level set a little bit more about the immigration policy, and please, if anyone else wants to talk about any other points, put it in the chat or take yourself off mute.
Yeah, I think your point about what does access even mean here is a really important one, because I think you're absolutely right that sort of immigration policy could mean so many different things, from actual like federal law to kind of the on the ground systems that are in place. And I think looking at the historical side, again, I think that's one area where when I was talking about all of these different kind of options for healthcare beyond only like going to a hospital and like sort of receiving treatment from a doctor, like that, kind of what we would probably most readily think of as accessing healthcare. I think the reality for many of these Irish immigrant women was actually much more varied and diverse. Like many of them probably would never even set foot in a hospital because that wasn't kind of the norm or custom, yet a lot of healthcare was still occurring in the home or in these different non-medical settings. So that's one reason why I'm really interested in this question of agency or constrained agency, kind of to get at the ways that these women who I study navigated kind of a challenging system, and potentially accessed options and resources that we wouldn't necessarily think of from a contemporary perspective as like a traditional healthcare institution, like a hospital or even like a physician attending a patient in the home or something like that. Yeah, so just being attentive to a much more varied medical landscape than perhaps we would think about today.
That's really intriguing. It reminds me of some topics that came up in some previous book discussion meetings where we kind of talked about midwifery, doulas, and similar themes too. So I'm just curious about the health outcomes outside of the kind of stereotypical healthcare institutions. Do we have any knowledge about whether the outcomes were better for those who potentially sought care outside of the traditional brick and mortar?
Yeah, so that's one of the areas that is really challenging to track. I think we can sort of, the best way to get at that question would be to think about how these Irish immigrant women were making these decisions, and sort of what their preferences showed about like how they viewed outcomes from different types of healthcare. So one example of this, which this is actually looking at an example in Dublin, so moving outside of the realm of the United States, but I'm working on a paper currently that is looking at in the 1850s, primarily in Dublin, many working class Irish women were choosing to go to workhouses to give birth, even when there were nearby maternity hospitals where they could have gone for free. And this kind of caused a little bit of a moment of uproar, especially among British Parliament and different authorities in Dublin, because they couldn't understand why these women would be choosing to give birth in a workhouse as opposed to a maternity hospital. And we have lots of different instances of this happening. And I kind of see this as an instance where these women are viewing the maternity hospital as an unappealing option, partially because it's unfamiliar, I think. It breaks with the custom of giving birth in a kind of a home environment surrounded by other women. And also in the mid-19th century, in many of these maternity hospitals, you have lots of infectious disease and epidemics happening pretty frequently that I'm sure that these working class women would have been very aware of. So you see that as kind of an unappealing option because they seem to have this understanding that their outcomes would probably be worse in that institution, as opposed to a workhouse, which we wouldn't necessarily think of as a medical institution, but most workhouses did have some medical staff there, and they were also, for a variety of reasons that I don't really have time to go into, but they were largely occupied by women. So it was this kind of female-dominated space that I see as almost a substitution for the traditional female-dominated home environment, that potentially for women moving to cities, they no longer had access to. So of course, that's outside of the realm of US history, and our own healthcare system. But I think it's just an interesting example of kind of, we have these historical examples. And so how do we try to get at like the women's own perspectives and maybe how they made these decisions about where to give birth or where to access healthcare, when we don't necessarily have their words recorded anywhere.
Right. Very interesting. Thank you. We do have a comment in the chat from Christina Austin. She says, I think conversations like this are important because I think many people are not aware of the historical issues and that some of these same issues persist today. Awareness and education, exclamation points. And there was a question also about why women would choose to go to the, you said workhouses or work homes instead of the hospital institutions. And she asked, was it an issue of trust and how people are treated? Could that be a potential reason why?
Yeah, that's a great question. I think trust and sort of the physician-patient relationship is absolutely central here. So I guess thinking about that example in Dublin, and then also Deirdre Cooper Owens, this narrative that she presents us in this chapter. Here we get from these medical journal articles, we get a little bit of insight into what the relationship between the physician and the patient would look like. And it seems pretty contentious. Often the physician's goals of treating a patient seem to be more about finding a new technique or finding a new way to publish and advance their career, as opposed to maybe listening to the patient and finding a path of treatment that would benefit the patient, sort of emotionally and physically. So I think from these little episodes we see in medical journal articles, we can extrapolate on those, and I think sort of use those to try to get at how potential patients would view these interactions with a physician, and all of the kind of negative qualities that we would see coming up in this patient-physician relationship. And I think just generally, I really tried to dwell on the point of like kind of what some of the primary nativist discourses were, because I think we have to understand how physicians at this time would largely be, native-born white men who were probably very familiar and probably, not that we can necessarily know for sure, but many of them probably believed a lot of these ideas about their Irish patients. So I think these women's hesitancy to enter a hospital setting as opposed to a more informal setting would absolutely stem from kind of this lack of trust and this this fear of possible negative and harmful treatment from a physician. And I think this is something that Dr. Cooper Owens just depicts so effectively and throughout her entire book. Like, she really highlights this contentious relationship between physicians and marginalized patients.
Thank you. We have another comment in the chat from Christina. I think some patients today feel that the physician is not interested in them as a patient. And what I was hearing as you were talking about the discord between patients and physicians is, especially when it comes to research and what is your ultimate goal? Why are you doing this work? What's the purpose? We have an opportunity, as many of us are a part of the biomedical research enterprise in one way or another. And as we look toward advancing health equity and eliminating health disparities, you have to put the patient and the community first. You have to do whatever work you're doing with the community. And yes, it is for the community, but it's not on the community. So involving all of the relevant stakeholders at the table, which is really everyone. So you have to have a huge table and that's okay. But I think we're up for the challenge. I know we're up for the challenge. And just to build off of Christina's earlier comment about trust and how people are treated, one wrong interaction can derail someone's future interactions or willingness to interact with the healthcare institution for the rest of their life. And then if they have children and family and friends who they have influence over or on, those kind of ideals and ideas get passed on. So then you have 3 generations and you're wondering, why don't we ever get vaccines, or why don't we participate in clinical trials? Well, it's because your great-great-grandparent thought X, Y, and Z. And it's like, we do not want misinformation and disinformation. So there's a huge responsibility for all of us, even those who are not patient facing, to take these opportunities to discuss these topics and really understand that interpersonal communication is really key to building trust, rebuilding trust, and earning the right to have discussions about these topics, especially from a research perspective.
Julisse, I really appreciate what you just said with regards to the fact that everyone needs to be a part of the solution and consider how patients in the community are treated, even individuals who are not patient facing. And I think that is sometimes where the part of the disconnect, and that we don't take the opportunity to make sure that everyone who's a part of the institution has that training and understanding and appreciate their impact on engaging with the community as well. And a lot of it has to do with even helping people to address their own biases. So thank you for saying that.
Thank you, Christina. Can we talk a little bit about the sexuality and sex work and the parallels between, this need to have economic independence, and not even in a way where Irish immigrant women were at a point where they could thrive. It wasn't like people were getting wealthy, but what are your thoughts on kind of the parallels about how Black women slaves were mistreated, over-sexualized, and not even in like a sex worker perspective? Can you discuss that juxtaposition between the two?
Yeah, absolutely. Yeah, I think so. We pretty frequently see sexuality as this kind of site of critique and intervention targeted at various different communities of marginalized women. So of course, with enslaved Black women, there's this discourse of kind of presenting them as overly sexual, like, which also occurs with the depiction of Irish immigrant women. And so we see this kind of common thread between in these very different cases, that sexuality is this kind of common thread of this way to criticize these different groups of marginalized women's behavior and kind of pathologize them in a way. And I think this is so frequent and effective because I think that it connects so many different kind of areas from it kind of connects supposedly like a biological or behavioral view of a community as violating larger social norms. So in the 19th century, women's behavior was often judged based on how they behaved sexually, like their ability to comply with certain social norms that were highly gendered. And then this, of course, became racialized. So different communities of women were expected to behave differently based on their race and their class. And with different marginalized groups of women, we see their, regardless of how they actually acted, they would never be kind of receive any kind of praise or acceptance, even if they met every single standard of proper sort of womanly behavior of the time. So I find sex work to be really interesting here because not only because it ties these kind of discourses of sexuality and sexual normativity to the labor market, which I think Dr. Cooper Owens also really highlights as a key part of this history. But then we see this as having both kind of implications on the popular imagination of these immigrant women as potentially a threat to public health because they would be potentially spreading like sexually transmitted infections through their sex work, and also kind of a threat to sort of this idea of moral well-being in how they're coming to the United States and entering the sex trade in disproportionately high numbers. So there's a lot of anxiety about that from kind of an American native-born perspective, seeing these immigrant women as a potential kind of drain on the cities that they're entering. Like that was how they framed it. But then also from the Irish perspective, there's a lot of concern about how these Irish women performing sex work how that would reflect on like Ireland as a whole. Like there's a lot of anxiety there about sort of how this would threaten an image of like national virtue or something like that. So yeah, I guess that's all to say that by looking at sort of the history of sex work here, we can get at all of these different kind of like high level abstract discourses and views and forms of nativism and all of that, and like these ideas being produced through this process of immigration. But then we can also look at kind of how sex work actually affected these individual women, how it in many cases allowed them to kind of pull together like an actual living wage, and that it probably did in some cases allow them to have greater flexibility and control over kind of their labor, because most of the other jobs available to them were highly regulated by whoever their boss would be, whether it's an employer for a domestic servant in someone's home, or kind of industrial bosses in a factory. So there's that benefit there, but then there also are, of course, the threats of kind of sexually transmitted infection, of violence from clients, and then, of course, the very severe policing that sex workers faced. So yeah, I think it's such a rich area for exploring so many of these different questions and themes of labor, health, sexuality, kind of regulation, all of those different aspects.
Thank you. Any other closing questions, comments, final thoughts? All right. Well, thank you so much, Charlotte. It's been a pleasure having you and learning a little bit about your work. Next week, we will be talking about the final chapter in the text, chapter 5, Historical Black Bodies and the Medical Gaze. We do not have a guest speaker for that, which means we will have to carry that conversation ourselves, but I'm certain that we will have a lot to talk about. So thank you again, everyone, for joining. Oh, I see one. Thank you for this very interesting and important conversation today. Thank you for being here, Christina, Julie, Tracy, Mackenzie, and Zena. And have a great afternoon, everyone.
Thank you all. Have a good afternoon.